So now we will speak about antepartum hemorrhage. Antepartum hemorrhage is an obstetric emergency and is very important because early and prompt management will prevent a lot of serious consequences. So what is antepartum hemorrhage? Antepartum hemorrhage in simple term is bleeding from the genital tract at any time between 24 weeks, which is the age of viability, and before birth of the baby. Antepartum hemorrhage can happen due to a wide range of causes. However, the most important causes are the placental related causes. As you know, there are two main reasons, which either placenta previa or placental abruption. However, there are other reasons of antepartum hemorrhage which you need to be aware about, like vasa previa, bleeding from cervical reasons, other gynae reasons. However, we'll focus in our presentation today about placental abruption and the initial management of antepartum hemorrhage in general. We will speak about placenta previa and vasa previa in different presentations, so please follow us for that. Antepartum hemorrhage can complicate up to 3 to 5% of pregnancy, and as I said before, it's very serious as it has a lot of perinatal and maternal complications up to mortality. It was known that 1/5 of preterm babies are born in association with antepartum hemorrhage, and there is no association between antepartum hemorrhage and cerebral palsy, which can be explained because of preterm labor. So if we start today with placental abruption, we need to know what are the risk factors of placental abruption, because by knowing the risk factors of abruption, we can manage to prevent it as well as reduce its occurrence and accordingly improve the outcome of pregnancy. The most common predictive factor is previous abruption. So any woman who had an abruption in previous pregnancy has a recurrence risk of about 4.4%. This if only one abruption. However, if she has two previous abruptions before, the recurrence risk will be 19 to 25%. Preeclampsia is another risk factor for abruption. Fetal growth restriction. Non-vertex presentation. Polyhydramnios. In particular, when we have a sudden rupture membrane or iatrogenic rupture of membrane with polyhydramnios. Advanced maternal age, multipara, low body mass index, pregnancy following assisted techniques, intrauterine infection, premature rupture of membrane, any trauma, smoking and drug misuse. It was found that as well first trimester bleeding increased the risk of abruption later in pregnancy and some maternal thrombophilia. So if we look at these risk factors, we will find some of them can be easily predicted and can be prevented, while others cannot be. For example, in polyhydramnios, we can manage to prevent iatrogenic rupture membrane, by that I mean sudden rupture of membrane, and this will avoid abruption at time of delivery. LPDC smoking, so usually advise the woman who has smoked to stop smoking or reduce it if needed, or reduce at least. Drug misuse, like cocaine and amphetamine, usually this woman should be advised in the antenatal clinic, if not advised preconceptional, to stop any drug misuse. Maternal thrombophilia was found to have abruption, and we will come into later about the preventive measures for that. So can you see here, as we see here, the prevention is to modify any preventable factor. So as we said before, tobacco smoking, cocaine, amphetamine misuse women should be advised and encouraged to stop that. Regarding thrombophilia, some studies goes for antithrombotic therapy, like low-dose aspirin or low molecular weight heparin in the prevention of abruption. However, till now, there is no good data to support the role of these drugs, and they are still used up as a part of clinical decision or as part of trials. So really, the Royal College was clear that they are not recommended at the moment for the prevention of abruption. Even if you think about it, these drugs increase the risk of bleeding. Accordingly, some studies say that you can prevent abruption. However, if abruption happens, it will be more severe because of bleeding. And as we said before, the second most common cause or second most important cause of abruption of antepartum hemorrhage is placental previa. That's why it's a very important practice that any woman who had bleeding in pregnancy, we need to avoid vaginal examination until we exclude placental previa. As we said before, antepartum hemorrhage is an obstetric emergency and is associated with a lot of maternal and fetal complications and serious consequences. That's why early and prompt management will prevent the consequences. So what are these complications? From the maternal point, recurrent antepartum hemorrhage can lead to maternal anemia. That's why we need, it's very important if there's a conservative management for antepartum hemorrhage to check for the full blood count and treat the anemia if present. Infection, maternal shock, if severe bleeding happen. And you have to bear in mind that placental abruption can be concealed. So bleeding happened inside the uterus, but not revealed, and accordingly, the vital signs of the mother will not be proportional to the amount of bleeding. So if the woman presents with a severe pain which is not explained by labor and the abdomen looks tense, even if there's no heavy bleeding visible, you need to be cautious and proactive because maternal shock can happen at any time. Renal tubular necrosis, and this is because affection of the renal blood flow. Consumptive coagulopathy, or as we say, SDIC, and this because of the abruption. The abruption consumes the clotting factors. Antepartum hemorrhage will call for postpartum hemorrhage, so it's a very important risk for postpartum hemorrhage. That's why if a woman presents in labor or before labor and had vaginal bleeding, you need to be ready for management of postpartum hemorrhage. These patients are at risk of prolonged hospital stay. They are at risk of psychological sequelae as well as complication of blood transfusion. This for the maternal complications. For the fetal complications, there is risk of fetal hypoxia with both intrauterine growth restriction and hemorrhage. That's why any woman who presents with recurrent antepartum hemorrhage, she should have a serial ultrasound scan for prediction of fetal growth restriction. Also risk of prematurity, either iatrogenic or spontaneous, and fetal death if the antepartum hemorrhage wasn't managed in the proper time. We need to be aware that domestic violence in pregnancy may result in antepartum hemorrhage. As we said before, one of the risk factors is abdominal trauma, and one of the common reasons of abdominal trauma is domestic violence. That's why any woman who presents with trauma in pregnancy, you need to ensure that this trauma is not as a reason of domestic violence, and you need to be ensure that the patient's safety. So now let's see that if you have a woman who is pregnant 34 weeks and she presents to the maternity assessment unit complaining of pain or bleeding or ruptured membrane, what is the rule of clinical assessment in view of an antepartum hemorrhage? The rule of clinical assessment here is to establish first, is this an obstetric emergency, or you can do a full assessment? Is there a maternal or a fetal life-threatening event, or you still have time to do your full assessment? This is what we call a triage. So you need first to categorize this patient. Is it category 1, which I need to do an action right now, deliver her for example, or it's a category 2, which I can wait a bit. And this process of triaging, you should include the history taking to find out pain, the amount of bleeding, the cardiovascular condition of the mother is very important, is she stable or not, and the assessment of fetal well-being. So these are the first 4 important issues you need to take in your mind, which is severity of pain, extent of bleeding, the vital signs of the patient, and the assessment of fetal well-being. So assume that the woman presents with a major or massive hemorrhage, or the woman is unstable, or you can't take a full history from her. In this case, you are facing a category 1 emergency where an urgent action must be taken, which is maternal resuscitation and delivery. Remember, the mother is the priority and she should be stabilized before the baby. However, if there is no maternal compromise or fetal compromise, here we'll go to a full history taking. So the full history taking, you need to establish the relation between the pain and the bleeding. As you know, silent bleeding will point towards placental previa, while painful bleeding will point towards placental abruption. Labor can be considered if the pain is intermittent. So again, this pain is, any patient with pain is a bit tricky. You need to identify, is the pain continuous or intermittent? Is it colicky or sharp? So if the pain is intermittent, it can be a labor pain, but if it's continuous or the pain, severity of the pain is really cannot be justified by contraction, so it's pointing towards an abruption. You need to find out, is there any risk factors for abruption or for placenta previa? You need to ask the woman about the fetal movement. And if antepartum hemorrhage is associated with rupture membrane, you have to bear in mind the vasa previa. And this is a very important differential diagnosis of an APH. We will discuss it separately, but just you need to bear in mind is if bleeding is associated with rupture membrane, either spontaneous or iatrogenic, you have to think about vasa previa, and you have very limited time to save this baby. Previous cervical smear history is very important, and is actually one of the factors which usually we miss in our history taking. So patients who present with antepartum hemorrhage, you need, as long as you're stable and you can take the history, you need to just to ask about the cervical history, because cervical cancer still can happen, and you need to exclude that. So you can't reassure the woman if she comes with spotting, especially if it is postcoital, and you can send her home based on just an erosion without asking about any previous abnormal smear before, or you had a speculum examination to ensure that cervix is okay. And the presentation of cervical cancer in pregnancy will really depend on the stage as diagnosis and the lesion size. Usually the woman will be asymptomatic in stage 1, and the only symptoms may be just postcoital bleeding or vaginal discharge. So please bear that in mind. Regarding examination, you will start with general assessment, where you have the vital signs of the patient, as we said before, to establish is she stable or not. Then you have proceed to the abdominal examination, and this will help you to find out is the abdomen tense and tender to touch, which will point to abruption, or is she soft and lax abdomen, or in rare situation like rupture uterus, where you feel that fetus separate from the uterine content. It's very, very rare. The woman can present exactly at this stage and she's still stable. And by abdominal palpation, you can predict the uterine contractions as well. And then you will go for a speculum examination. And remember, any examination, you need a chaperone and you need a verbal consent. You need to tell the woman about why you are doing the examination, and you need to tell her the finding immediately after. And by speculum examination, you are aiming to see the amount of bleeding, you are aiming to examine the cervix and see dilatation or any abnormal lesion. Digital examination is not preferred in case of antepartum hemorrhage until you exclude placenta previa. So you need to check her anomaly scan and her previous scan history to be sure that there is no placenta previa. If there is no previous ultrasound, please refrain from doing vaginal examination till an ultrasound is done and exclude a placenta previa. So now to the third step, which is the investigation. So we start with history taking, examination, and now the investigation. And the investigation is quite simple. You need to do a full blood count, you need to do a coagulation profile. If patients are Rh negative, you need Clay-Howard test. to see if she will need an anti-D, but we need to know how much anti-D is needed. You know that any patient who is Rh negative and she presents with vaginal bleeding needs anti-D. Even if she has her routine anti-D at 28 weeks, she will need anti-D. And you start with the initial dose of 500 international unit, and then you do the Clee-Howard test, and based on the result of the Clee-Howard test, you will understand whether she will need more or not. This 500 international unit can cover up to 4 ml of fetal maternal hemorrhage. And please don't depend on that for abruption because it's not diagnostic at all. These patients need global save. These patients, as we said before, at risk of complications, so we need to get liver function test and the kidney function test. Ultrasound need to be done if not done before, and definitely assessment of fetal well-being by cardiotogography. When doing the blood investigation, we need to cross-match blood. And this initial hemoglobin, remember that the initial hemoglobin is not a reflection of the amount of bleeding. It's a part of physiology of the pregnancy that the woman can bleed by maintaining its hemoglobin, and this initial hemoglobin is not a reflection of the condition. That's why if the clinical condition calls for blood transfusion, you need to be ready for that and not to wait for the hemoglobin to come back. And in such circumstances, there's a point of care test, which is a bedside test as hemoglobin may be useful, as well as platelet count, because if the platelet count is low, this may indicate a consumptive coagulopathy, which is DIC, and accordingly it may need prompt management. However, if the bleeding is minimal and there's no indication for blood transfusion, in this case you can wait for the for blood count to come back. After that, you already had your investigation, the woman is stable, then you have to decide what you need to do. You did your maternal investigation and you have no concern. You had your fetal investigation, including the cardiography, and there's no immediate concern, as well as your ultrasound, everything comes back as normal. Then you have to start management of the patient. In these patients, usually they don't need any hospitalization. However, if the bleeding is a bit heavier than spotting, or there is concern of placenta previa, or you are concerned that there may be an underlying abruption, in this case you can hospitalize her. So really hospitalization is not a black and white issue. Hospitalization depends on the clinical judgment. But definitely if the patient presents for second time for antepartum hemorrhage, in this case you have to think right about hospitalization. And at this point, there is no recommendation about the duration of the inpatient management. Some protocols may go for admission up to 24 hours after stoppage of bleeding. Some may go for admission till the patient is till we have no concern. But and again, it will depend on the patient's safety, how far she lives from the hospital, mode of transportation, support she's getting from home. So really, this item of hospitalization and the duration is not a black and white issue. You need to consider the whole picture before sending the patient home. About corticosteroids, these patients are at risk of preterm labor. That's why if the patient has an ongoing bleeding or a recurrent bleeding, in this case you have to consider a course of corticosteroids if she's between 24 weeks and 34 weeks and 6 days. But again, if it is a one-off episode of spotting and no more active bleeding or ongoing bleeding, then giving steroids too early may actually not be beneficial, because as you know, the steroids, its duration will last up to 7 days, and after that there is no benefit really, and recurrent course of corticosteroids will not be helpful as well. That's why if the patient has one-off bleeding with no ongoing symptoms and you have no concern about her, you may not give it. But if it is continuous, then you have to give the corticosteroids. And here will come the role of tachylysis. Tachylysis is as we know, it's contraindicated with antepartum hemorrhage. We shouldn't delay labor in a patient who is bleeding because maternal and fetal consequences are serious. However, on the other side, if the patient is not heavily bleeding, or you are one time to give her steroids, you decide to admit her and you're giving her steroids, you want to get the time because of prematurity, then you can consider the tocolysis. But this decision needs senior involvement, because really it's a balance between the maternal and fetal status and the amount of bleeding, prematurity, so there are a lot to take in one picture. So senior decision must be taken before giving tocolysis. But definitely if you are going to give tocolysis, you need to give drugs which is not harmful to the cardiovascular system. We have seen that nifedipine is associated with maternal hypotension, so it's better to avoid it in case of antepartum hemorrhage. But again, as a general rule, tocolysis are contraindicated with vaginal bleeding, and if you're going to give it, the benefits must outweigh the risk of giving it, so you have to consider that carefully. However, if the patient will decide for conservative management, so the bleeding is minimal, it can be recurrent, spotting, but not affecting the maternal or fetal well-being, her care, it must be a consultant-led care. So if it was a midwife-led care and she started having this bleeding, she must be consulted care, and she must have serial growth scans, because as we said before, antepartum hemorrhage puts the woman at a risk of intrauterine growth restriction. So we must have serial ultrasound scans to be sure that there's not a complication not happening. So if you go for labor and delivery, so first the question is when, second the question is how. So when to deliver, actually it depends on the maternal and fetal condition. So we'll assume the worst case scenario is intrauterine fetal death because of placental abruption. In this case you have to deliver, because there's no point of waiting. Plus, if the bleeding was severe to cause fetal death, it can cause maternal death if you left the baby in. And we know that if the bleeding from placental abruption, the only way to stop it is to deliver. But if it is a recurrent bleed, there is no maternal or fetal compromise. Usually we aim for deliver around 37 weeks. Because if the woman is stable and baby is stable, there is no indication for early delivery before 37 weeks. But if the woman presents with an antepartum hemorrhage after 37 weeks, then you have to balance the risk of waiting more time and having more bleeding, which can affect the maternal or fetal well-being, with the risk of delivery around 37 weeks where the baby is more or less mature. So usually if the ABH is spotting or the blood streaks through the mucus, so it's unlikely to acquire active intervention. However, if it is really a minor or a major ABH, and by minor I mean it's more than spotting, then you have to aim for delivery. Vaginal delivery or cesarean section, the rule is vaginal birth. Cesarean section is only for maternal or fetal compromise. If time is not on your side, in this case, cesarean section is the answer. But as long as you have the time for induction of labor, or you have time to achieve vaginal birth, vaginal birth is much better than cesarean section. And remember, these patients are now consultant-led care, so they require fetal monitoring in labor. Remember, these patients are at risk of postpartum hemorrhage, and accordingly, active management is important. Regional analgesia is recommended as long as the mom is stable and the cardiovascular status is okay. However, you should involve the anesthesia as early as possible in these cases. So if you have a patient who is antepartum hemorrhage and she's in labor, the anesthesia need to be aware in order to assess the risk, assess what he needs, do his bloods, review the bloods. So usually it's a teamwork to achieve patient safety, and this teamwork involves the anesthesia, the neonatology, and the midwife. So you need to involve all your team and be clear in your communication using the SPAR, which is situation, background, assessment, and recommendation. So we'll achieve the best outcome in our situation. After delivery, remember the rule of thromboprophylaxis, and there is a postnatal checklist for thromboprophylaxis from the Royal College. Any patient need this checklist. You need to check her condition after delivery, because postpartum hemorrhage more than a liter, for example, is a risk factor. And then you will decide whether she will need prophylaxis or not, and how long. Anti-D is very important in Rh negative ladies. So anti-D should, at least, as I said before, a 500 international should be given, and then Coley-Howard test should be done. These 500 international units cover a full ml of red blood cells. However, if more Coley-Howard is still positive, she will need more anti-D. This patient at risk of postpartum hemorrhage, so this patient will need close observation after delivery to be sure that she's not bleeding. This patient will need debriefing. Remember that antepartum hemorrhage is a complication in pregnancy, and this mom or the partner will be psychologically stressed, traumatized. So you need proper debriefing. And antepartum hemorrhage will call for detox and incident reporting. The neonate as well is at risk of anemia and fetal compromise. That's why pediatrician or neonatologist need to examine the baby after delivery and before discharge. In case of extreme prematurity, the mama and the partner need to be aware that this baby may need admission before delivery. That baby may need admission for special care unit and may require some time for that. And you need to involve a senior pediatrician before delivery. The role of conservative management is not clear enough. However, if the mom is stable, then you can delay delivery, especially if the baby is less than 26 weeks. However, as we said before, maternal safety comes first. So if the bleeding is life-threatening or there's an evidence of cardiovascular compromise, in this case, consideration for delivery should be taken. Usually we give this woman a follow-up appointment 4 to 6 weeks after birth, and this in order for medical and psychological support. And again, this woman usually will require more debriefing in this follow-up appointment. Thank you.